Welcome to Stand Up for Doctors. I'm your host, Kim Downey. Thank you very much for joining us. This channel is dedicated to amplifying the voices of doctors, other healthcare professionals, and patients as they share their unique struggles, triumphs, and passions. My mission is to build connection and create advocacy for healthy doctors, driving positive change that benefits both doctors and patients. This is a space for everyone who cares about the future of healthcare. If you appreciate this content, please like and subscribe now. It really helps the episodes reach our target audience. And I would also like to announce that we're hosting an amazing physician retreat October 9 to 12, 2026. It will be a weekend to connect, empower, recharge, and celebrate. CMEs will be available. Please reach out for more information if you're a doctor interested in attending, or if anyone would like to sponsor our retreat. We can create sponsorship to fit your budget. And the registration link will be in the show notes. And I'm very excited to welcome Dr. Cheryl Martin and Dr. Shannon Foster. Thanks for joining us today, Cheryl and Shannon.
Thank you, Kim, for having me.
Thanks very much for the opportunity. It's lovely to be here with you both.
You're welcome. And by way of a very brief introduction, because I would like you to share more about yourselves, Dr. Cheryl Martin is an emergency medicine physician by training in Australia who prioritizes organizational well-being, safety culture, and leadership with 2 decades of experience working across healthcare settings in both Scotland and Australia. And Dr. Shannon Foster is an acute care surgeon, administrator, certified coach, mediator, international facilitator, and award winning educator. And she's also the founder of SMF Facilitation, which she'll tell us more about. And today we'll be talking about rebuilding culture, preventing burnout before it begins, and maintaining longevity of practice given all of the challenges facing healthcare today around the globe. We need doctors and we need them to be well, and these three topics are inextricably intertwined. So I always start off by asking what you'd most like our audience to know about you as we begin our conversation. Cheryl, would you like to go first?
Thank you, Kim, for the opportunity to be here with you both. And I have lots of questions for Shannon. What a bio. I think I'm going to flip it. I saw somebody very recently start with their failure bio, and I think that we'd be here all day if we started with my failure bio. But I think everything is a work in progress. What to know about me? Yes, I've been 20 years a doctor. I think that the areas of priority through my career have definitely been evolving through that space. But I am grateful for the opportunity to be on this podcast because I really appreciate the work that you do, Kim, because I do think, as you have said, that a lot of what drives me today is knowing that our clinicians in healthcare space are critical to the mission, and many of them are called to do basically their best work for patients and to serve our communities. And if we don't look after them, we can't deliver on the mission. So I suppose that's really why I'm here, and that's what keeps me going forward today.
Absolutely. And I hope that you know Dr. Simon Craig in Australia.
I do, yes.
And so he read one of the first books that I read. He wrote one of the first books that I read in these spaces about, delivering love to medicine and healthcare. And it was his book that opened to my eyes that these issues are ubiquitous around the world and over time. And that's why I love having the two of you on together. And even the way your professions intersect with each other, right? They show up in the ER and then you refer to a trauma surgeon. And sometimes,
Yeah.
there can be even physician relationships with each other that can be adversarial, whether it's, anesthesiologist and a surgeon and all of that. So I love to bring doctors together to have these really powerful conversations to see that at the end of the day, as Dr. Kevin Poe said when I interviewed him, that we all want the same thing, which is, the best care for the patients.
And I think
So,
these conversations play out globally. The more I kind of reach out to colleagues around the world, and we're having the same conversations. So thank you for connecting us.
you're welcome. And Shannon, what would you like us to know about you?
Oh, goodness. Well, first, Kim, I'd like to pause and say thank you again so much for the opportunity. You've been so warm and welcoming, not just to me, but I think to a lot of us. And when we first had the opportunity to speak, it was a random reach out, a random connection. And you were such a font of kindness and of sharing your story, of candor and vulnerability. And one of the things that I think we even highlighted at that first conversation was your willingness to bring people together and to share creates a platform where we all feel empowered and able to do the same. And since we are talking about physicians and physician wellness, one of the major issues that we all have is work is hard, life is hard, the struggle is real. And we don't talk about the struggle and we're not transparent about the struggle. And our colleagues don't often support each other in the struggle. And the systems often don't support us in the struggle either. But what helps us all is when there's a space of safety where we can discuss it and talk about it and bring it together. And you, my friend, have created that space where when a lot of us don't feel safe, in the places where we work or with some of our colleagues or even in a more public setting, you've made a public setting where you're bringing people together where we can talk about these things so beautifully. So first and foremost, we really, really need to acknowledge how important that is: vulnerability, safety, and bringing our common issues together because we're all experiencing them together. So thank you. Tangent back to myself. Goodness, that's a big opening question of what's a fun thing to know about me or not. I love what Cheryl just said about the failure bio is often more important than the real one, because that exemplifies our opportunities to learn and to grow and to adapt and to evolve. And my bio or my current professional choices in consulting and facilitation work comes from a place of experience. I've had a lot of it, some good, some bad. And in the last few years in particular, I have put myself in some of those places of challenge. I've worked in part-time, in academia, in community, in rural, in urban, in all of these things on purpose to give myself insight and to build skills so that I can pay it forward with all of my colleagues in the profession. So when someone is coming because they need help or they're struggling or there's a human resource problem or their culture is so toxic that they're just struggling, they don't want to give up their career, but they're so disgruntled and dispassionate by some of the things that they encounter that we need to rebuild it and find a safe way for them to recreate and design and practice the way that they want to. So all of those random titles that you gave me highlight sometimes the different skill sets or approaches that are necessary, either with individuals or with teams, to open up those safe spaces for conversation, to bring the reality of sometimes people don't know that they're bullying or don't know that there's harassment happening or don't know that they've allowed things to propagate. So having a team that's willing to talk about those issues requires some pretty intense facilitation and mediation sometimes. But as the clinician who's done it all from the inside, I can doctor speak them in a more, shall we say, aggressive and directed fashion to do that. The random and fun thing to know about me, I'm an avid reader. I love sports, but my secret passion is frogs. And that's a whole story unto itself. So there you go.
Well, we'll have to dive into that maybe off camera. I would love to hear more about that, which I didn't know. And I do want to say that I recently got to meet Shannon in person when I was driving through Pennsylvania with my mom and my husband. Actually, we had a great chat at a coffee shop. So I love all of this. And as we start with our conversation on the topic for the day, rebuilding culture. So, Cheryl, I know that you really talk about safety culture. Would you like to share a little about your work in this area?
Yeah, we've just actually had our Australasian Doctors' Health Conference last weekend, so this was, front and center, and it's really interesting to see how the conversations are evolving in that space. And I think, we it's been 25 years since To Err Is Human was published, which really kind of drove the safety and quality movement for patients. And that really also moved the narrative from one of name, shame, and blame individuals to think about systems and root cause analysis and how we can support everyone to our patients to be safer within the context of a complex system. I think in terms of the conversations that then have subsequently evolved it's a bit like I suppose the clinician wellbeing movement. It is still quite early in that piece, but we are moving more to think about systems and structures. And there's been a lot of conversation around psychological safety and the importance of that, obviously made famous by Professor Amy Edmondson, and particularly how you established that rapidly in flash teams, for example, within the emergency department. I have a few colleagues that have done some really interesting work, and it turns out all the small moments matter. So
Mhm.
setting the tone as a leader, but huddles, after action reviews, little debriefs, checking in and having each other's back becomes particularly important in the emergency department, which is pretty much a laboratory of errors. I think that was what Pat Croskery described. But I think the other aspect of this, which I am really encouraged, and there's a lot of conversation here in Australia and New Zealand at the moment, particularly in Australia with our new work health and safety laws, is the psychosocial safety, which, is different. That's a responsibility of organizations to enable basically safe workplaces. So that's our job hazards like fatigue and rostering. And as you said, bullying, discrimination, harassment, which we know we are not our best selves when we are under duress in complex systems. And our certainly the data we have around this is stubbornly it's high and not budging. And I think the new we're going to say legal levers that we have here in terms of employer responsibility to look after the psychosocial context of their workplaces is also an opportunity to elevate psychological safety, because we now have to go in and speak to the people closest to the work who know the most about their jobs. They know the pain points, the pebbles in the shoes, the rocks, the boulders. And now we have to identify hazards, we have to measure them, and then we actually have to come up with ways to solve the problem and improve conditions. So I think that actually is a way in potentially to elevate everything. So I think this is the current conversations that we're having. And again, of course, there's awareness advocacy, but it's all about the action and actually involving the people closest to the work in doing that and enabling it at all levels. So I'll probably stop there, but I'm sure Shannon will pick up some of that. I'm sure you
No,
both
I,
will.
I I love it, and it's resonating deeply with me. Again, for my own personal experience and perspective, but this is exactly what I do with my clients, whether individuals or teams. Try to pick and delineate where are the areas where we can create improvement. What is the problem of the system? What's the interpersonal dynamic? What's the trickle down effect because people are tired, because resources are scarce, because we're currently understaffed? So there's always what's the, as you said, root cause, but then what are the little manifestations? And the little manifestations, when colleagues aren't playing well together and treating each other with respect, sometimes they just need grace and forgiveness because they're tired and they're overworked and they're stressed. So it's not always that someone is trying to create a toxic culture. It's not always that interpersonal dynamics between different physicians. And you called it, I mean, I'm a trauma surgeon. So working with lots of other people, orthopedic surgeons, neurosurgeons, medicine doctors, infectious diseases, the ED, anesthesia, you're in and out all the time. And what we see, and I'm sure you've seen it as well, and while I hate to hear that it's a worldwide phenomenon, I'm also glad to hear that it is a ubiquitous phenomenon, meaning the very environment of advanced healthcare that we've created to deliver these awesome and beautiful things causes the same problems all the time when we haven't paid attention to the people dynamics and how individuals have to work together. And even a simple example from you, from ED to trauma, I'm the general surgeon on call. You're the ED physician. Hey, I've got this. You need to come and see it. Oh, that's not for me. Call ortho. Oh, that's not for me. Call someone else. The hot potato phenomenon that happens when we all pass the buck, even in terms of clinically interacting with patients, bespeaks the much larger environmental and cultural issue of accountability and transparency, right? Because if I go and do that work and take care of that patient, but it's not really for me, well, no, I'm overworked and I'm not going to get to see my other patients and I'm not going to be on time to the OR. So then I'm going to get in trouble and then my reimbursement's going to change. And then some administrator's going to tell me I didn't meet my timeline. So you can see every single one of these little things that people do maybe was never meant with disrespect, maybe was never meant to not provide optimal patient care, but evolved in an environment where we've been turned often into cogs in a machine that are expected to be interchangeable, that are expected to work in 15-minute increments, that are expected to never have complications. And we all know that's not the real world of medicine. It's hard, it's complicated. It's beautiful, it's wonderful. The patient relationship is the most intimate and beautiful thing that can possibly happen. There's a level of intimacy that goes beyond spouses and children and all of the above when someone says, come to my body and take care of me. But when we're not creating the place and the space for that most intimate of relationships to blossom, then that relationship too is under stress and tension and leads to dysfunction. So if your physician's not happy and short strapped and running around on empty, then inevitably that outcome, that patient interaction, that patient care is going to suffer. So that's my soapbox. That's what we advocate for. That's why fixing all of these problems, if someone is being harassed or having bullying or isn't happy with their culture or is on call too many times in the month or doesn't work well with colleagues, my guess is there's system-based factors that we can all help and remediate so that those individuals will want to stay a medical practitioner and stay interacting with patients longer. And that's the goal for us all, I think.
The only thing I want to pick up on, and again, was something we were discussing at the weekend, and I kind of look at, I think there was a global study of nursing and medical students by Elsevier a couple of years ago, and the interesting thing is we still have plenty of people signing up for the mission, and it is a meaning and purpose that drives them. They particularly, weren't turned off through COVID. They look at the misinformation. They want to come and help. And so, that's our value proposition in healthcare. We have a competitive advantage there. But, on the flip side of that, they were concerned about the mental health, about the impact of the work environment potentially on them. And I just, I kind of look, apart from being a laggard in the psychosocial safety space, when we look across industry and healthcare, I just also, we also have a group, particularly now we are moving towards an MD program for our physicians in Australia. So they are bringing other skills, be that from the arts, from engineering, from other areas of science, and they want to come and help solve complex problems.
Mhm.
And if we don't, I think it was Jonathan's Global Burnout Summit. There was an amazing speaker with an HR background, and he said, we tell people no while they are trying to solve problems. And I am just concerned that we see a lot of this move. We don't have entrepreneurship encouraged within the system.
Mhm.
I see a lot of my younger, very talented colleagues having to step out and innovate and then maybe try to partner back. But we then lose that talent. We lose the clinical facing, their clinic, they actually potentially decrease their clinical hours or leave to actually think about how they can use tech solutions or to solve. I mean, axing the facts would be the kind of classic on that. And so I suppose that's an area I just think that's in addition to listening and learning organizations, how do we build that back in?
So I love that you're sharing that, psychosocial responsibility is a team and a system responsibility, not solely, right, individual responsibility. And when you said that now you're required to address those things, is there like some like Australia law or something
Yeah,
now?
so our work health and safety legislation has just been updated. In fact, in Victoria, where I am, as all states have now have the update, and it took place here just on Monday. It came into effect, and so yeah. So I mean, obviously we've had work health and safety laws for a longer period of time, but that is a recent update.
Wow, so that's wonderful. I think we need to look at that. That's one thing we could be looking at here.
It's good.
And yeah, and also as far as preventing burnout before it begins, Shannon, would you like to begin speaking to that?
Sure. I think that's exactly what we're alluding to, that a lot of what we are doing now is reacting and trying to fix things that are already maybe suboptimal or complicated or help someone salvage or fix their career after there's been a problem. So the key is absolutely that, Kim. It is preventing and targeting and stopping the train of that momentum before it can even happen. And education in one area, communication, right? How we talk to each other, how we interact, how information is disseminated, what the expectations are. But it's all about bi-directional transparency and bi-directional accountability. If I know what my job and my expectations are, and you know what your job and expectations are, we're going to work a lot better together. And if everything that I'm going through I tell you, and everything that you're going through, you tell me, we're going to work better together. So a big area in prevention is working on that communications training and teaching people that conflict can in fact be very healthy. It doesn't have to be negative and ugly. Bringing conflict where people have differing opinions and differing ideas and being willing to change, that is exactly what's necessary. And I'm tying this into the comments that you made about pipeline development, who's coming behind us. There's so much energy, there's so much vigor, there's such great ideas. And bringing those people into the fold and into the forefront is what always leads to change and innovation. And in fact, as a trauma acute care surgeon, this idea of how many hours we work or don't work or whatnot, FTE we call it, full-time employee. Well, why
Same
is
here.
it that it took until the 20 teens and the 2020s to define what does it mean to be a full-time employee? Why is it that physicians for however many years have just been expected to work and do the job, however many hours that takes at whatever time of the day and so on and so forth? So that's part of the thing. It's this younger generation coming into the workforce. It's always the generation behind that says, wait a second, that's not okay. What do you mean I'm just going to work? Like, well, how many hours is that? And how many weekends is that? And well, how am I supposed to take care of this many patients by myself? Why don't I have partners or why don't I have advanced practitioners? So it's the younger generation as they come of age, so to speak. Myself, probably, 20, 25 years ago, I'm sure Cheryl, yourself, as we all come forward and say, hey, these are the issues where things aren't working. So we need to really amplify those voices. And so, again, in this environment that we're creating for what is an open culture, those voices, the person that's been in practice 6 months or a year or 2 years, are just as important as the people that have been in practice for 40 years. And I would further throw out there, maybe somewhat controversially, that if those individuals that have been in practice for 20, 30, or 40 years never had a problem in the culture that they were raised, whether it was work hours, whether it was discrimination, whether it was gender issues, and had to be told to advocate for those other issues, then they're probably not the ones to be leading the charge for change. It's those young, energetic, passionate individuals who have grown up with a different perspective and are bringing that perspective to the limelight. And that shouldn't be squelched, that should be amplified, and those ideas should be given all the credibility that they're worth. And then hopefully we'll keep them taking care of us and other patients for much longer.
Very nice. Well said.
Thank you. I'm an
And
energetic kind of girl.
yeah,
So
and
I'm
Cheryl,
getting a
what
lot of
would
energy from this conversation.
it's how I
yeah.
roll. It's how I roll. I always
Thanks,
come to it
Kim.
that friend, client, whatever it is that we're doing, I very much believe that our energy is contagious.
Yeah.
I know that sounds silly, but if I bring my troubles to you or something heavy to talk about, we can still have that conversation where I'm energy outflow and not energy suck. And if
Mhm.
everybody tries to do that when they're interacting with others, then I think then the takeaway is that the messaging is stronger, the impact is stronger, and we all walk away feeling a little bit better than wounded, even when we're talking about some of these negative things. So a very, again, positive energy and elevate the conversation. That's part of what I'm all about.
Kim, can I ask Shannon a question? Do you mind?
Absolutely.
Uh-oh.
I prefer to be on the other side of the mic.
Yeah.
I really like you were discussing, the difficult conversations, leaning into conflict. I heard in your bio, I think that Kim introduced you, you do some mediation, and I have a colleague who does this actually in the UK as well. Is that something, is this something that you do within the system or you do outside? And could you see opportunity where you could build that in? Because I don't really remember through my training having visited much of the challenging conversations, the conflict negotiations. I've certainly done more subsequently, but I really feel, and I know there's not a lot of time through training because you're trying to learn all your clinical skills, but how do you build that in? So what do you think that looks like at its best?
Oh, yeah, I love it. I wish I had a clear answer for how it's its best. But again, I fundamentally believe that ethical training, communications training, meaning difficult conversations, how to work better with your colleagues, it has to be integrated into what we do, especially with our residents. This should be a part of all of their clinical training moments. Sit down, let me teach you how to have the conversation. Let me teach you how to interact with the difficult colleagues. We should be doing this intrinsically instead of after the fact. When you're asking me specifically, as my opportunity in the last few years evolved into this space of rather than just my consulting work where I'm helping with quality or I'm helping with the protocol or I'm helping a trauma center with their verification, it became well, Foster can help you with this and she can get you through this legal problem. And if you work with her, maybe you won't have to get a lawyer. and things like that evolved in that way. But for me to feel comfortable in those spaces, just like in my clinical hat and my administrative hat, the same for you and the same for many of our colleagues. If someone says, hey, do this, then I want to know that I know the right language and the vernacular and have the right training to interact there. So my choice to proceed with non-medical kind of communications training has been very specific to that. But one of the things that I put out there when I'm doing professional training, I love educating, so I do leadership development and other kind of professional trainings, and a lot of that is incorporating here's how to really negotiate. Here's what it looks like, and defining facilitation is a way to bring people together in a group, that it's not about you as the leader in the room, it's about everyone else and getting them to talk. Or mediation, when individuals are having a conflict that isn't clearly going to be resolved, there's not going to be an impasse. Okay, well, let's set up some ground rules and actually go through this process so that we can get an outcome in a reasonable amount of time. So using those other tools, I think your best answer is communication training should be for everyone. Using those specific tools in the right setting. Am I helping with a human resource problem? Am I helping a problem between two colleagues? Am I helping a division deal with the aftermath of someone was fired or let go because of an ugly event? Oftentimes, who helps that group? They're all hurting. They all need to talk about it.
Yeah.
And it's just like, nope, work as usual, life goes on, and they're all feeling disrupted. So I use some of those other approaches to try to really bring people to the table to talk in those psychological safe spaces. And I, again, completely agree with you that communications should be, just as ethics has to be, a part of early medical training from the time of medical school through residency, and should be used in real-time application throughout, and teaching people some of these skills, which we might intrinsically be doing anyway, putting words on them, helping them to quantify things to know if they're successful or not, helping people to analyze, did I use the right communication tool with this family who was really struggling with this end of life decision, giving them that opportunity to learn and grow and give feedback. I think a lot of places are working on that and making it more integral to their training, but that is definitely something that is needed. I don't know if I answered your question or if I rambled
You
a bit.
did. Yeah, no, thank
Yeah.
you.
But is that so help, Kim, if I can shoot right back to Cheryl. So when you're talking about your pipeline and your education, whether you're medical students or residents, help enlighten as to some of the system differences that we would see for non-clinical or non-basic science materials in those years.
So I don't do much the way in education with our undergraduates here, so I couldn't really comment on that. But my understanding is they're certainly listening to some medical deans at the beginning of the year that there's a lot of really interesting and exciting things happening. I'm still not confident that we're necessarily then bringing them into a training environment where we're continuing that universally. And so I still think we've got that bit to get right for our doctors in training. But yeah, in terms of those other core skills that you discussed, how you kind of just then permeate that in through
Mhm.
advanced training, because you kind of spat out as a specialist, and then, your consultant interview will be, how do you manage conflict? And how you're just expected to know how to do these things.
Right,
And
right.
everybody memorizes an answer, and then they have to do it in real time, and then you really learn, and then you think, actually, and I have to say, full disclosure, failure bio, I just shied away from any difficult conversation or conflict for a long period of time, and I think that's still a work in progress. But I've realized, I kind of like the high challenge, high support framework, but the more you lean in and connect and realize actually the common humanity, and that, I think my colleague, Dr. Anna Baberstock, I don't know, Kim, you need to have her on if you haven't already. She's in the UK, and she does mediation like yourself, and this the position, interests, needs, and if you can bring down people to just actually look at each other across the room and realize, oh, what are we actually even fighting about? Or, having what was the source of this conflict? And
Hmm.
either there's emotion, there's a laugh, there's a
Oh, so
cry,
much.
there's a gasp, there's a, oh, geez, this is, and
Yeah.
I that's fascinating. Mm.
Well, and I also really love your candor about saying pivoting away from difficult conversations or emotional barriers. Of course, we all do that, right? And I'm coming at a place from lots of gray hair and lots of experiential learning because, right, no matter what we do, what is it?
Likewise.
10% is book learning, 20% is formal education, and the other 70% of our true skill set is experiential. So I've made lots of mistakes. I'm sure I have offended people. I know I, whether meant to or not, did this wrong and that wrong and made this career mistake. And I've had the chance to learn and grow in retrospect with support, with mentors, with colleagues. And that idea of paying it forward, this is exactly what I think Kim is getting to. And this is exactly what this community is all about sharing those learned experiences, being candid, waving the flag. I am imperfect. I make mistakes. I am not always great. I'm sure at who knows what hour in the morning I was awful, right? When someone is bleeding to death on my feet, I'm not kind,
Mhm.
right? And so learning all of those things about ourselves are huge, but creating a team and an environment where all of that is forgiven and given grace and understanding,
Yeah.
that's what we're lacking. Because
Yeah.
I want my surgeon to behave horribly at 2 a.m. in the morning if they saved my life.
Yeah.
And we have to give them the skills and permission to do that, but yet what's the line of doing that? Did you throw something at my head? Did you call me bad names? Were you right? So there's still lines, and all of that is proactive, preemptive training and simulations and talking through these scenarios. And we've lived in an environment where individuals who are known difficult colleagues have been protected and allowed to get away with those sorts of disparaging dialogues and behaviors for so long because, oh, well, they are a good surgeon, or oh, they're an awesome researcher, or oh, they're a really good educator, but the rest of the time they're horrible people. I don't want horrible people in medicine. I want good people in medicine. I want doctors to be interacting with patients and the patients to like those doctors. And we all want the same. And again, everyone with transparency, with open conversations, with education opportunities, everyone wants to do that. And so recognizing that we all deserve grace and forgiveness and can move forward and grow together, that's what this culture very much needs to be. So I love that you say those things and expose yourself to vulnerability. I'm exposing myself to vulnerability all the time. This is how I've learned and grown. And I want everybody else to do that too. Just like we want all of our young people to come and say, this is what scares me. This is what I'm overwhelmed by. This is why I'm not sure if I still want to be a doctor. This is why I was going to go into clinical practice, but now I'm going to pivot into innovation because. Well, we need to hear every example of because, not just forget about those people because they left. Their stories of why they chose to leave or why they chose to go to part-time are just as important, if not more so, than the individuals who just stick to the standard and expected career path because we get to learn a lot from them.
Mhm. Well, I love all of this. And as we wind down, I feel like we have to have a part two. There's so much more to talk about. Cheryl, how can our listeners get in touch with you? And also, did you want to mention your podcast?
Sure. Yes, like you, I prefer to be on the other side of the mic, Kim. Thank you. My podcast is the Mind Full Medic Podcast. So two words, bit of a play on mindful because my mind is always full. And I get to interview fabulous people like yourselves across not just Australia, but also, yeah, we've got guests from around the world now, and I learn so much from my guests. So I can give you a link for that. I'm also on the usual platforms, not very much on Instagram, but I am on LinkedIn.
So send me any links and we will put them in the show notes. And Shannon, how can our listeners get in touch with you?
Well, first, Cheryl, I'm going to have listen. I bet anything you say is awesome. But I think I put my info up here, SMF Facilitation Services. It's smffacilitation.com. Personal email, sfoster at the same. There's a phone number there. I'm on LinkedIn. I'm always at college meetings and trauma meetings. Easy to find. So please reach out and find me. I like to think if I can help someone save their career and stay in the profession, then it's been a good day.
Thank you
Well,
both for your work.
yes. Yeah, and thank you both for being my guests. I'm so excited to share this episode.
Thanks, Kim.
You're welcome. And in closing, to move the needle in healthcare, we all need to raise our voices and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.